This program's topic is on patient progress charting and SOAP format for notes. And my special guest is Jim Ott, CPO and NovaCare Area Clinical Director. Welcome, Jim. It's a pleasure to have you as our guest and resident expert on this very important topic.
Thank you. It's nice to be here, and I'm really glad to have the opportunity to share my experience writing progress notes using the SOAP format.
Jim, why is it that with all the possible topics to present, clinical charting procedures are so important and the first subject in a series of NovaCare presentations?
Well, Byron, I feel that it's really our sole responsibility as a practitioner to deliver the highest quality patient care that we possibly can. And I think it's one thing to say that we do that, and it's yet another thing to actually demonstrate that we do that. So I believe that it's the progress note that is the vehicle for validating the fact that we have, in fact, delivered that high-quality care.
What specifically is it that makes charting so important?
I think really the progress note is the most important document in the patient's file. It really speaks to our purpose as a practitioner and as a company. It contains all the vital information that pertains to the care that we provide our patient. It has the patient's medical history, their current status, any action that we take that's relative to the care of the patient, and any plan for future care for that patient. Another feature of the progress note is that it sometimes is the link between us and other healthcare providers. And it helps us to meet the standards that are set, monitored, and enforced by the medical community.
It's interesting that you bring up the communication among healthcare professionals. It's my understanding that the patient file is confidential. How would other professionals have access to the file?
Well, Byron, generally speaking, our patient files are confidential. There are some other ways, however, where other professionals would have a need to have access to our progress notes and our files, even within our own company. We're the largest orthotic and prosthetic company in the country. We have patient care centers from coast to coast, and there are always opportunities for our employees to transfer from one geographical location to another. And as they enter into their new office, then they're going to have access to those patient files in order to continue the care with the patients. And there are some other reasons, vacation time, sick time, that where another practitioner will have to step in and continue the care. And another situation is when we are contracting with managed healthcare organizations, and in order to get the contract and maintain the contract, we have to abide by their documentation requirements. Excuse me, bro.
I'm sorry.
The progress note also helps us to maintain our standards for our care. As we go out into the hospital and see a patient, we then have to document the care that we provide that patient. At that point, physicians, nurses, and therapists will have to have access to that note in order to continue the care of the patient.
Okay, how else might the way we maintain our charts affect our relationship with managed care?
Well, the progress note really helps to ensure reimbursement. And as we contract with the managed healthcare organizations, they have a right to come in and audit our patient files. And at that point, the progress note really verifies that we have, in fact, delivered the quality of care and met the standards that they require. The managed healthcare organizations also make some of their final decisions based on that information in our documentation. Reimbursement, refunds. They'll also take that information and use it as sort of trending information, if you will, in order to determine whether or not to authorize any future procedures. Will they allow this, or will they not allow that? And that information comes out of our patient files. Additionally, the progress note serves as a legal document. It is admissible evidence in the court of law. And one thing for sure, our memories we won't be able to recall all the specific facts. And the complete record really helps us to recall all of those specific facts. And in a court of law, the record will take precedence over our memory.
Those are definitely sound reasons for clinical charting. It sounds as if this is fairly complicated and time-consuming.
Well, it's not really a difficult process. I do believe that there is a learning curve to it, however. But one thing that I would hope to see is that practitioners really see the value in a good progress note, and that value equals better care. So from that standpoint alone, I think the process is worth learning. And if, in fact, the practitioner is saying that this is a difficult process, they're probably not following the basics or the fundamentals of patient charting.
I didn't realize there were basics to charting. Isn't just writing down all the information you think is important about the patient and the services provided all that's really necessary?
Well, I think one thing that can happen here is that this process become a haphazard process. All we have to do is just follow the fundamentals. We want to gather the right information in the right order, and the right order is the actual sequence of events with the patient. And then the right outcome will be produced.
Why don't you explain the fundamentals to me?
Well, the progress note is written on this form. It's a universally recognized form. And one thing that we need to remember is that there's really only clinical information that's recorded on this form. There's no financial or other information that should be on that form.
Isn't the financial information important? Why wouldn't it be kept in the patient's chart?
Well, the financial information is really very important. It, however, is written on another form. But the point about that is that the financial information has no clinical value. So we want to keep the information separate, the clinical information on the progress note form and the financial information on the financial form.
So we record the notes on the progress note form and only record clinical information on the form. What else?
Well, we want to make our entries permanent. We want to use black ink or a typewriter, and the reason for that is for reproductive quality. We want to make sure that in the upper margin of the form we write the patient's name, and that goes on every individual progress form that's in the chart. In the left-hand margin, we're going to enter the date. And if we make more than one entry in the same day, we want to make sure that we put the time of any subsequent entry so that we are able to distinguish one entry from another or one event from another in that same day. Another thing that's important is we need to have good penmanship. If the note is not legible, then it's really not going to be good for anyone, and most of all the patient.
But if you're someone like me who has terrible penmanship and I'm in a rush to write something down, I can't even read my own writing.
Well, then it's okay to print the entry if you want to. Or if your office has the equipment, then go ahead and dictate the note. And you can remember that using point form is okay. And by that I mean we don't need to write any long, drawn-out, grammatically correct sentences. And after we've made our entry, we want to sign it with our full signature and our credentials. If the progress note is typed, either by someone else or by yourself, then we want to make sure that we proofread that note, and because we are the ones who are responsible for every bit of information that goes in that patient's file. And one other thing, we never want to skip lines. We want to make our notes continuous, and that is usually happens if there's a space or two between each dated entry. And that's important, particularly in cases where we might run into a legal situation we're dealing with, and it only leads to suspect that we have an opportunity to fill in something after the fact, and we don't want to do that.
Now, this doesn't seem all that complicated. I only count 8 fundamentals to charting. Use the standard form, only record clinical entries, make entries permanent, always include the patient's name, record the date and time, write legibly, sign each entry. All notes are continuous. Are there any other fundamentals?
Yes, there's another one that's really very important, and that the entries must be timely. And probably the best time to make that entry is right after we see the patient. Or we might even write the patient's progress note as we are going through the interview process. There is one golden rule, however, in terms of the timeliness of the entry. We must make that progress note entry the day that we see the patient. It's very important. Tomorrow we're only going to see another group of patients. And when that happens, the charts are going to stack up. We'll have a tendency to be in a hurry to get through them. And in that process, we're just going to leave out some of the information that needs to be in that progress note.
So now I have the 9 basic fundamentals to patient charting. Is that all there is to it?
Well, there really are no set regulations regarding how to write a progress note. There is, however, a very effective progress note system called the SOAP format.
Is SOAP charting an internal NovaCare format?
Now, SOAP is really a universally recognized and used charting system. Hospitals use it, physicians use it, therapists use it. Even if they don't always use it, it certainly is recognized.
What exactly does SOAP stand for, and what makes this format so valuable?
SOAP is an acronym. The S is for the subjective element of the progress note. The O is for the objective element of the note. A is for assessment, and P is for the plan element of the progress note. Each element represents a task or a function, and within each element we document very specific types of information. It's really a systematic approach to documenting the events and actually providing the care.
Can you explain in more detail what exactly each letter of the SOAP acronym means? You stated that S represented the subjective element. How do I use that to help me take better clinical notes?
The subjective element is always the first one in both the documentation process and the actual patient event. It represents the patient's perspective or someone else's perspective of what is taking place with that patient. It includes such things as the problems the patient is having or their history, whether that be long-term or short-term, and if it's only been 3 days since we last saw the patient, then we have 3 days of history to collect. It might be something like the patient telling us they have pain. The patient responses are oftentimes provoked by the pertinent questions that we ask in the interview process, such as, when did your pain start? Then the response to that answer, or question, is what we document in the subjective element of the progress note.
When you want to record why they have pain or complaints and how you solve the situation?
Well, not at this point in the progress note taking. It's really only time to solicit information, gather it, and then document it. We only want their story or their opinion, if you will.
Can you give me an example?
Sure. We might write something like, patient complained of pain at the ankle. Or another example would be, I like the looks of my new leg. Or as a result perhaps of a phone call with a physician requested a drop foot orthosis. It's subjective information. It came from someone else. And as I said, it's oftentimes the response from someone else as a result of questions that we ask.
Then that brings us to O for objective element. What exactly would I want to include in this part of the entry?
The objective element is what we observe. It's something like if I were to be observing a patient's gait status, what I see is what I document. Or if I'm performing some tests on a patient, like I'm testing their muscle strength or I'm testing range of motion, what I'm observing is what I document. Or if I'm looking at an x-ray or skin condition or the wound condition or the general fit of the orthosis or prosthesis, what I observe is what I document. And we are not interested in my opinion or anyone else's. Here we're just looking at the facts.
What if I'm confident I know exactly what the problem and the appropriate solution is for the patient?
Well, at this point we're not ready to really record that. We are only interested in recording the facts, and we want to be very specific about those facts. We might say something like, 1 by 1.5 centimeter blister noted on the anterior distal tip of the residual limb. Or if I'm looking at an x-ray, for instance, of a scoliosis patient, what I observe is left lumbar curve equals 33 degrees, right thoracic curve equals 31 degrees. We want to avoid making any vague statements, saying something like, residual limb appears swollen. That's really too vague. You know, what does swollen mean? We want to be more specific and at least quantify it. You know, is the residual limb moderately swollen or minimally swollen? We want to quantify it and be very specific.
I now see the logical flow of where the SOAP method is going. Now that you have recorded the subjective and objective elements, you now move into the assessment. Is that right, Jim?
Right. The assessment is really the next logical step. And it is based on information we got out of the subjective element and the objective element, what the patient told us and what we observed. At this point, we're ready to make a judgment. And if we really want to, we can call it our diagnosis. It's simply what is taking place and why.
And from here, you naturally go to the final segment of the entry, the plan, right, Jim?
Yes, we finish with the plan. And the plan is the action element of the progress note. It's where we record any treatment that was provided, and it's where we record any course of treatment we plan to provide in the future. It actually sets up the next follow-up visit for the patient, which in turn is going to help us satisfy one of our quality assurance programs called the Patient Recall Program. But that's going to be a topic for another day, I'm sure.
This sounds rather straightforward. Can you give me a few examples of some actual clinical notes?
Sure, I'd be happy to do that. Let me first kind of go about this in a roundabout way. I'd like to first describe an actual patient event, and then we can get in and demonstrate how to document that event. And the event might go something like this. A prosthetic patient comes into my office complaining of pain on the anterior distal end of his residual limb. Well, he took off the prosthesis. I noted that there was a blister at that location. I also noticed that there were some sock impressions at about 1 centimeter proximal to the patellar tendon. Well, it was obvious to me that the residual limb had shrunk and the patient was bottoming out in the socket. I simply added a 3-ply sock to his existing 5-ply fit. And after the patient walked on it for a minute, he said, "Hey, this really feels great now." Well, then I took off the prosthesis and I noted that now the sock impression was at the proper location, directly over the patellar tendon. Then I proceeded to instruct the patient on the proper sock management techniques so that as volume changes occurred, then he could know how to manage that situation. And then I set up a follow-up appointment for 2 weeks later. Now, before I actually demonstrate how to write the note for that particular event, I'd like to take us back 2 weeks earlier for this same patient and show you the progress note that reflected the previous visit the patient made to the office. So now let me take you back to 4/2/93, which is 2 weeks earlier. And we see by the progress note here that in my subjective element, I've simply documented patient in office for fit and delivery of a BK prosthesis. There's a quote here. The patient said he is doing okay, and that was a result of a question that I asked him, "How are you doing today?" There's another quote, "Anxious to get my new leg." In the objective element of my progress note, I observed the stump wrap was in place, the wound was clean and dry, and he had moderate edema on this day. On this day, we fit the temporary prosthesis with a 5-ply sock, and his gait was stable and the alignment was good. And today he was using a walker and partial weight bearing. And skin tolerance to the socket was noted to be without problems, and the patient's weight on this date was 165 pounds. Now my assessment is the patient is ready to begin ambulation with physical therapy, needs gait training. And in my plan, The patient was advised to ambulate to weight tolerance and begin transition to a cane as directed by the physical therapist. I advised the patient and the physical therapist on the proper sock management for volume changes that I knew would occur. Patient and physical therapist advised to call me whenever there's a problem or questions, or PRN. And then I set an appointment for 2 weeks later on 4/19/93. And then I signed it with my full signature and my credentials. Now what I'd like to do is take us to the progress note for the event that I just described, which is 2 weeks later, dated 4/19/93. My subjective element on this day is patient complained of pain and blister on end of stump. There's a quote here that the patient stated, "Problem started about a week ago." Another quote, "Have not been walking much for a week." He keeps the prosthesis on all day. My objective element, or what I observe, is anterior distal tibia blister noted, and it was drained and dry. Today the patient was wearing a 5-ply sock, and the sock impression was noted 1 centimeter proximal to the patellar tendon. The distal stump was red. The patient was weight-bearing or partial weight-bearing with a walker, and he had an antalgic, or he was obviously avoiding pain while he's walking, so his gait was just unstable. The patient's weight to date was 165 pounds. My assessment, or my diagnosis, if you will, the stump atrophy caused the loose fit, resulting in the patient's current problems. My plan, I added a 3-ply sock. Now he has a total of an 8-ply fit, and he increased the weight bearing on the prosthesis. I advise the patient to add socks as he begins to feel a loose fit in the socket. And I also advise the patient to expect further shrinkage. And the patient is to call me whenever there's a problem, with emphasis, not to wait until his next appointment if any problems come up. And then I set an appointment for 2 weeks later again on 5/3/93. I signed it with my credentials. Now that I've gone through that, what I'd like to do is to discuss with you a couple of points that I hope will illustrate how our progress notes reflect the continuity of care that we provide. In the subjective element, I mentioned that the patient stated that the problem started a week ago. What that tells me is, as I refer back to my previous progress note, I documented that I asked the patient to call me if they're having any problems. Well, that's going to cause me to start thinking, hey, I've got to do something more to get this patient to understand that I'm here to help him whenever he has the problem, and not to wait until the next appointed time. Another point in that progress note, I documented the patient today came in wearing a 5-ply sock. Well, referring back to my previous note, I observed that the patient left my office that day wearing a 5-ply sock. So he's not really managing the sock situation according to the volume changes in his residual limb. So I've got to do something to reinforce this idea of what he's got to do to help himself. Another point is, down in my plan, I noted that the patient today is wearing an 8-ply fit. Now that's going to be valuable information for me in the patient's future visits, because then I can go back to my previous note and see what ply of sock the patient left my office with the last time, so that I can keep a record of that and the patient's progress each time they come into the office. And so I think with these points, what is important here is that I think this helps to illustrate the fact that we are, in fact, documenting continuity in our care, and that, in fact, helps to influence our ability to deliver that continuity of care.
I noticed that you even wrote the letters SOAP in the notes. Is this standard?
Yes, I did write that, and I write that every time. I think that SOAP helps us to keep our thought process clear and orderly, and it's really an excellent habit to get into every time. It keeps the notes uniform and it keeps them consistent. And SOAP really does ensure clinical accuracy and positive clinical results. It really is the exact sequence of the patient event itself. It provides a very clear picture of what happened.
So it really is that simple. S is for subjective information gathered from the patient or someone else like the daughter or wife of the patient describing the patient situation. O is for objective, the clinical facts and only the facts, what is observed. A is for assessment, your clinical evaluation based upon your subjective and objective findings. It could also be seen as your diagnosis. P is for plan, the course of treatment that takes place. This is the action element of the note. It sounds very straightforward. Are there other bits of information that will make SOAP charting easier and effective?
Yes, there are other things to consider when we make our entry. We want to make our entry timely, we want to make our entries accurate, and we want to be as concise as possible. Remember that I said point form is okay, there's no need for the long sentences, and we want to record only the facts. That's all that's necessary.
What if I make an honest mistake during an entry, like write in left instead of right, or write AK instead of BK, or even worse, get in a rush and write Mr. Jones' information on Mr. Smith's chart by accident?
Well, one thing for sure, mistakes do happen. And it really won't be a problem if the problem is dealt with correctly. We want to remember that we don't ever want to try to erase our entry or white it out. We simply need to draw a line through the mistake and then sign it and date it. And in some cases, if we were to maybe project a problem in the future, a legal problem perhaps, it might be a good idea to have someone come in and witness that by signing and dating it also.
So what it sounds like you're saying is an honest mistake in the notes is not a problem as long as you don't try to make it look like you're trying to hide something. What other hints can you offer to make charting easier?
Well, we want to avoid generalizations. Writing something like, the patient is happy with their orthosis. You know, what does that really mean? Happy is a relative term. So it might be more appropriate to say something like, the patient liked the fit and the cosmesis of the orthosis. One general rule to consider here when writing progress note, and this helps me a lot to make sure that I get the right information in the patient's file. I'm thinking as I'm writing a note that, hey, if I'm not here the next time the patient comes in, the practitioner that follows with my patient is going to have access to all the right information so that they can make the right judgment and decisions in treating the patient during that current event. And it just seems real practical to me, and that's just sort of a reminder to me of how to make sure that I get all that information in there that should be there.
What was the most valuable information you learned from a Medicare auditing experience?
Well, we know that there are two situations that an auditor will pick up on in the audit process. And basically, the auditor is looking for the documentation which supports that there is, in fact, a change in the patient's physical or medical condition, or that there's documentation in there which supports that there was an actual change in the condition of the device itself, which warranted a replacement of this device. And if there is no supporting documentation in the file to say that, yes, the replacement of these devices was warranted, then we're going to get a big red stamp at the end of that audit that says, payment denied, refund immediately.
That sounds very severe. Can you give a specific example that you've experienced?
Yes, there was one particular case that I recall where a prosthetic patient came in and their residual limb had atrophied. It was very obvious. They were wearing 25-ply socks. So we did what we thought was the right thing, and we fit the patient with a new prosthesis. Well, Medicare paid us for the services we provided. And then we experienced an audit. Well, this was one of the files that Medicare looked at, and they didn't find any supporting documentation in that patient's file that would indicate that there was a valid reason for replacing that prosthesis. So in this particular case, Medicare ruled that NovaCare must refund the money.
Are you not able to appeal such a decision? It sounds a little unfair to the practitioner who has the patient's proper care in mind.
Well, at this point, there's really very little we can do to appeal this process. Medicare is very clear in their guidelines for these kinds of situations. Medicare will pay us for our services, and part of the service that they pay us for is having the proper documentation in our files. In that particular case, we lost the appeal. And there was also a case where if the proper SOAP progress notes were written in that patient's chart, we probably wouldn't have had a problem.
Okay, in closing, Jim, tell us what the bottom line is with regard to progress notes.
Well, I can sum that up really very quickly. I really believe that a proper progress note will definitely influence our ability to deliver quality patient care. And I think most importantly, it's really the right thing to do for our patients.